I think probably a few more folks that are joining here momentarily. Yeah, I think maybe we'll start in a minute.
Great. All right. You tell me when, Brad. Maybe 11:02, something. Brad, should we get started?
Just gonna say it's 11:02, so let's do it.
Great. All right. Thanks everyone. Thank you. Happy June 1st. Happy almost summer. I'm really excited for today's discussion. We're going to try something a little bit different today. We're gonna try to listen more and speak a little bit less. We're going to speak a little bit more at the beginning, but then we're going to try to reserve a lot of today's discussion time for discussion. I'm excited for the conversation. Thank you for your input. And I just want to express again, your input and feedback is really critical as we're embarking on this journey. So thank you for the investment and time. I've learned a lot from our discussions to date, and I expect to learn a lot today. If you hop over to the next slide, I just wanted to open with just a quick response to some of the really thoughtful requests we got in our last meeting. We heard 5 things from you last meeting. The first is on goals and strategy. At the beginning of the meeting, several of you expressed a desire to recenter on the overall goals. And we spent some time flashing up a slide, which we'll have in just a second, on the kind of the overall goals of the project. We invited discussion then and offline. And in part because we did not get any offline feedback, we feel really good about the overall goals that we outlined. What we'll do today is review, there was a request for clarity on some definitions of key terms like equity. So we'll put up a working definition and open up for discussion there, but that's our main response on number 1. On number 2, we had a lot of really thoughtful discussion on social determinants of health or health-related social needs. What we're planning to do is use all of or almost all of next month's meeting, the July, for an in-depth discussion about this topic. So if you give a little bit of grace, we're going to just tee that up a tiny bit today, but we're going to reserve the bulk of that discussion for July. We think it's an important topic that merits its own discussion, so that's where we'll cover it. Third, we heard some concerns about timeline and maybe the timeline being a little bit too quick to enable the extended discussion that you all felt was important. We've heard you. We have updated the timeline. We're moving it back to give more opportunity for discussion. Fourth, we heard your desire for a more discussion on data and evidence, and that's where we're going to spend the bulk of today's discussion. I know we sent over a lot of material on the evidence, along with a poll to ask you all what portions of that evidence would be most relevant so that we can curate, and we're going to spend the bulk of today walking through some of that evidence. Not all of it, of course, we can't, but the pieces that we think are most important based on the feedback that we received from you. And finally, we had some requests for better record keeping. So we have a website created with meeting minutes and recordings and stuff like that. That website is live. So let me just pause there. I hope those 5 things, I hope they're first of all responsive to what we heard last time. And that the follow-ups on the right-hand column make sense. I'm just going to pause for a moment. If folks think we missed anything, I'd love to hear it. Otherwise, we'll move forward.
This is Ellen. I apologize that I've said in emails that I have a different perspective, I guess, on the literature and some of what I read in the appendix. And I need to do my own lit review, and I need to look at the articles because you have different ones that you pulled out. I mean, it's all about what you use for search terms and how you look at an article. So I really need to do that work. Unfortunately, the legislature's in session, so I have not done that for this meeting. I will get that to you, and probably in writing, because I don't want to take up a lot of time on that. But I'll get that to you at some point. And I'm hoping that we can have these, just because we say like today is the day for data, that doesn't mean that it's over for any of these things. We can talk about health-related social needs and other things down the road as they come up. I'm hoping the process is flexible enough for that.
Yep, makes sense, Ellen. I'm aligned. Looking forward to your comments, and happy to get them in writing or a meeting, whatever makes most sense. I certainly agree this is a complicated topic. We're not going to cover all in just a couple of minutes. We did want to just try to be responsive to your the committee's ask for data and information, so that's what we're going to try to do today. But it won't be the only the only bite at the apple, so to speak, for sure.
Thank you.
Anything else here? Okay, then I'm gonna move on. And I think Brad's gonna just touch on the first topic there on the overall goals. And Brad, I'll hand it over to you.
Thanks, Guy. And so again, just we spent quite a bit of time on this at the last meeting and asked for if there was any other thoughts wanted to in writing or email from the council. And we hadn't heard a lot. And I think obviously this doesn't these goals and strategies don't tell us exactly where we're going to land at the end of this process, but obviously it's a starting place. And I think we feel comfortable with this starting place, acknowledging there's obviously room for conversations down the line as to where this takes us. So next slide. And the other thing that Guy teed up is we wanted to clarify just put some definitions in writing to help along the way. We won't go over these necessarily. I'm not going to read them out loud, but I do want to give folks a moment to review if you haven't had a chance, and also to provide any comments or questions that you have about this. Obviously, it's helpful to have a common vocabulary and understanding of where we're headed and why and what we're talking about.
And similar to before, this isn't the only bite at the apple. We don't need to overwhelm you, but so if outline you have comments or edits, feel free to send them as well.
So seeing none now, well, again, not the final opportunity, but just wanted to, again, set the stage. If you can go to the next slide. The other thing we wanted to make sure we touched on is, I think, some folks, Karen, go ahead before we.
I just wanted to quickly comment on the definition of equity, which seems to me to read like a definition of equality, and those are two very different concepts. So I would just ask if you would consider taking another look at this. And I don't want to belabor the point. I do think it's been an issue in past discussions, particularly around the maternity bundle, that that's a word that gets thrown around a lot, but there isn't necessarily the action behind it to make it a part of the program. So I just wanted to be careful about that.
Yeah, if you have a suggestion or Karen for definitional change or something, definitely would be happy to hear from you on it. And obviously, I know Health Equity Solutions cares a lot about this, and so welcome your expertise in providing us some information. We're happy to look at it. Okay, next slide. So again, wanting to give a little bit more context to where the primary care payment reform fits in, why it's important, kind of some of the scope of this, and I think also acknowledge that kind of what we're talking about in terms of the scope of the work and primary care payment reform, that we may struggle to, we're not going to completely improve everyone's biopsychosocial well-being from 0 to 100%. And I think acknowledging that we think that primary care payment reform or primary care is a foundational component of the healthcare system that can help identify and address some health-related social needs and social determinants of health, but it's not going to be the whole solution. And so I just think it's important that we say that. And on the left-hand side, you'll see this infographic that I think has been used multiple times at the bottom. This is what goes into your health. And at the bottom, you'll see 20% is about healthcare. The remainder of other things are individual health behaviors, and then social determinants of health. There's other things as well that may not be included, like genetics, et cetera. But just acknowledging that we know that healthcare delivery systems have an important role to play. And we think it's foundational, but we also acknowledge that there's a lot of other pieces that go into this, and that healthcare potentially can help interface with some of these other areas, but won't be the complete solution to addressing and improving people's biopsychosocial needs and well-being. Next slide. So a little bit more context. So we think it's on the left hand, you'll see the infographic where primary care is sitting at the middle. And we think that primary care can play a central role in helping coordinate and identify needs and provide referrals and other things to help address those needs. So you'll see outside of primary care, specialty care, dental, pharmacy, health-related social needs, behavioral health, long-term service and supports. These are just, this isn't saying this is what primary care is going to be, addressing or actually, providing housing directly, but there's opportunities to play a central role in actually strengthening primary care so that it can help coordinate and identify and address some of these at some level. And so we think that through this work that primary care, that the foundation of primary or strength the foundation of primary care can be done. And we want to think about this through providing tools, supports, and flexibilities. That first bullet there that can enable primary care to play this foundational role. The second one is really thinking about enhancing the focus on measuring and addressing disparities in care. So obviously we need to understand where those disparities are so that we can address them and measure them and monitor them and drive towards accountability of improving them. And then investing in primary care. So providing funding to support historically uncompensated activities and care delivery redesign activities and infrastructure, obviously dependent on state budget approval. But if we're asking people to do more, that will be difficult without resources to do that. So Polly, I see your hand up first, and then Ellen.
Yeah, thank you, Brad. I guess the question, and I appreciated the infographic and, again, primary care playing an important role, but not like the whole component. In the goal language, it talks about upholding a model of mutual accountability, and some of the language around providers expected to fully address members' needs and take accountability for member outcomes. I guess, how do we balance that with acknowledging that it's on that infographic, maybe 50% might fall within the realm of, primary care's influence and not necessarily. I think the way that goal language is worded puts a lot of accountability on the provider and acknowledgement that this model will provide tools, expertise, resources to make investments. But I feel like we might need to revisit what's the accountability on primary care. And also, I think you'll touch on this, is what other, social supports might DSS envision building out that would really address, filling some of those gaps. So I would like to see that mutual accountability flushed out a little bit differently than how it's worded today.
Thanks, Polly. And I think understandable, we need to be more precise about what that accountability and what the accountability is for. Is it accountability of the outcome? Or is it part of a accountability of access to resources and process? And I think that's, I think part of the work of this group, we would want to discuss about what's that level of accountability, because if is accountable for someone just to be housed tomorrow if they're homeless, that may not be, I think, probably not very realistic with how right now it's definitely not. It'd be hard for, I think, us to imagine that us holding someone accountable tomorrow or even in a year or two from now for something along those lines. So I think that full accountability will need to define what that means. So I appreciate that comment. Guy, anything else you want to add to that?
No, I appreciate them both as well. Definitely agree. I tend to start jumping to policy solutions too quickly. So I'll just say, your comment for me brought up questions on, for example, social risk adjustment, right? If I'm serving a population that is more disadvantaged and that causes, and that drives up their healthcare needs, how do we ensure that's incorporated into the model? The only other thing, Polly, I'll say on your second point on, what else DSS could do in the mutual accountability, totally agree. So we're, just to say again, I'll say on the next slide, we're planning to use the July meeting to brainstorm in that question a little bit more in depth. So would love your and others thinking there.
Yeah, Ellen, you're up next, I think.
Thanks. I share that concern with the tension between, healthcare being responsible for 10% of and social needs 40%. But then in the next slide, primary care is the hub, it's the center. And I think it is, I agree with Polly that that's a whole lot of responsibility. And, providers aren't taught to do that. And it's a lot to put on there. I hear the same thing, when I talk to teachers about domestic violence. It's like, this is too much to ask from us. We should get a training in it. But I also concern about primary care being the center of a hub of so many important things. I probably would put health-related social needs more at the center and put primary care maybe around that. I think everybody should be, I don't love having a center to that hub, frankly. I think it should be more of a web and everybody talking to everybody else appropriately with, guardrails around it. I also worry about the idea because some of the appendices, and I don't want to jump ahead, but talk about primary care capitation. And if you are going to then hold them accountable for all these things and also basically have control over, referrals and things like that. But then I guess, primary care capitation makes me think about a world where more and more care is provided by very large health systems. This just all makes me extremely tense, and it's not what providers are trained to do. So I think they should be a part of the mix, but the center of the hub makes me very nervous. And also the money, the incentives have to be, the money that's saved can't all go back to the healthcare system. It has to be shared with the community services and the other folks who are more responsible, 40% responsible for our health outcomes. So I guess I'm concerned, but about the same things, but from a different perspective than Polly.
Thanks, Ellen. And I think by having primary care at the center in this case, I think it's more about for those individuals who are accessing care through primary care, that they could help link to other resources and coordinate, but wouldn't necessarily be the only source. I don't think we would ever want that to be the case. So, for example, there's going to be many people who, for behavioral health or mental health services, might be their primary source of care for a good reason. And I can't imagine that we're going to be in a place where we're going to say, no, you have to work through primary care so that you can get your health-related social needs addressed. I think this is more that a role that primary care could play for those individuals who are seeking care through primary care. It's not a only access. It's a opportunity for access and coordination that we can incentivize providers to do and help, enhance those services that are provided, but it's not the only way. We wouldn't want to make this I think based on our goals, we want to maintain access. It wouldn't be a, plan to make a gatekeeper approach. It would be more of this is opportunity for coordination and linking existing services and helping provide resources that primary healthcare systems, maybe not just even primary care providers, because obviously providers on their own, I don't think you're right, are best ready to do this, but there are support services or other services within that primary healthcare hub. And again, not saying this doesn't need to be the center of everyone's care. Again, other places could be the center depending on individual needs. Do you want to add to that?
No, I think it'd be great to call on Mark. Yeah.
Yep, Mark.
I think, well, can I just follow up on one thing as well?
Sure.
The control and authority, I'm comforted by what you say, but I'm also worried about the money. And that the savings that there needs to be an understanding, like Polly said, that if we're going to expect people's improvement in health, we have to look at the 40%, at least as much as we do the 10%. And the savings can't go always back to the healthcare system.
Yeah, I think that'll be part of our discussion in terms of how we're thinking about what does primary care redesign look like and how do we think about addressing some of these and resourcing appropriately. And I don't think we have answers for this, but I appreciate the thoughtfulness, Ellen.
Great, thank you.
Mark?
So thanks, Brad. And I'd like to build off what Ellen said, and also apologies for being a few minutes late. I also wanted to make sure I express gratitude for the data that you put together and also for the accommodations on timetable and approach. So thank you for that. So Ellen took us to this question of payment methods. And I think that while we talk in the near term, more precisely, what are the goals we're trying to achieve? And then what are the capabilities that need to be built in primary care to achieve those goals? And then how does primary care operate within a system? All of the parts of which need to be working together to achieve certain outcomes. There's going to be the conversation about the rewards, the returns. So you would drive reductions in avoidable use, hospital or other. What about the returns? And so one of the things that I'm reminded of is that even beyond Buddhist medicine for people with diabetes or CHF, there is work that occurs alongside what happens in primary care. Hospitals and community partners in the north end of Hartford are working on building a grocery store with nutritious foods to provide access to everyday people that has both preventive health implications as well as chronic disease management implications. At Vita and Stanford Hospital and other community partners have worked with community members to build community gardens. So as we think about those interventions, and then also efforts to remediate housing that is brought with triggers like molds and pests and lead and that sort of thing. Those activities are collective, place-based activities. They rely on the strength of communities, hospitals, FQHCs to do. They augment and enable success of what we're envisioning with primary care, I think. And so this isn't a today conversation, but as we think about the economic benefits to the Medicaid program that are generated based on a set of activities, some within primary care and some outside, how do you think about moving beyond traditional total cost of care models where all the returns go to primary care, and an approach that actually values the contribution community organizations, hospitals, and FQHCs make in other ways that are place-based and that enable both prevention and effective chronic care management?
Thanks, Mark. Yeah, I think obviously we may be challenged to include all of those things in the scope of this work, because obviously will be some limits, but acknowledging that there's multiple players, or just to say community-based organizations and obviously larger health systems, FQHCs, primary care, these all interface in different ways, I think is what you're kind of saying, and they all can play a different role in how do you build that out?
My point is, if you design a primary care model, and if this is going to be basically a ramped up ACO model with HRSN coverage and new primary care capabilities, and 100% of the savings go back to primary care, you're not actually creating an investment return for the folks who do the work that enables or on which the success of primary care depends. I don't think that that's like a tomorrow discussion, because once you've baked it into a model today, you've basically foreclosed using the returns in Medicaid, which your graph shows are only 20% what happens in healthcare. You're basically shutting them out of the formula that is the basis for determining how funds that are saved are reinvested. Couldn't emphasize that enough before. If this process forecloses other options, it's problematic.
Thanks, Mark. I think there may be a little bit on the next slide in terms of where some of the thoughtfulness about how we're thinking about addressing overarching issues, but I think what you're saying is basically, what do we do if we're building out a model where there are savings attributable to the state, and how does that occur? And so appreciate that. I'm not sure I don't think we're necessarily precluding that as part of this conversation today, as opposed to just saying we think that primary care plays a key role in helping navigate the system. And I think acknowledging, I think Mark Mazzelli's comment that the patient or person's at the center of this, and I agree, people, sometimes people won't go to primary care, so they're going to go elsewhere. How can those other things be resourced? I think there's outstanding questions about what we realistically are capable of doing as part of this process. But I think it's an important point, and I appreciate you bringing it up. Guy, I don't know if you want to weigh in any further on that.
I think you hit it well, and I hear you, Mark, and you aren't the only person to make the point. So let's a little bit of a lead into to the next slide. I think that that's exactly why we wanted to use the July meeting to talk about health-related social needs. So I'm just gonna really briefly tee this up. This isn't the focus of today's discussion, but I have a particular question, which is, we're going to spend the July meeting talking about this topic. It's clearly really important and very much on your mind. The question I have for you is, what information would you like to have in advance of that meeting so that our discussion in July can be productive? Just to provide a tiny little bit of framework, we're not starting from scratch on this topic. There are a range, and by the way, listed here, I'm focusing just on the stuff that DSS does, recognizing that many of you do a ton of work in this space. So this isn't meant to be comprehensive. This is just taking a DSS lens just for a moment. There are a number of initiatives that we have in place today. This committee's work is thinking about primary care payment reform, but that obviously fits into the bigger picture of what else could DSS be doing on this topic. As many of you know, other states have gotten 1115 waivers related to health-related social needs approved recently. And in the July conversation, we want to talk about this whole topic. So I guess for now, our goals are very modest, which is I'd like just a brief discussion on what information you need to make sure that the July discussion is productive. I'll play MC. This is my side. Ellen, go for it.
I guess, I look at the list and I know, this is how it works. Again, I get why, but often the initiatives that are planned are in response to an opportunity, from CMS or something. They say, somebody went to a conference and now that's the big thing. And it just frustrates me that we're not planning based on what our needs are and what we're seeing. So I'd like to know what kind of flexibility there is. And we could ask for a lot of things, but first of all, I don't know what the needs are now, will be later. So flexibility down the road, and also monitoring to look at what's working and what's not. And, how far can we go with these, these extra savings to support communities? This is Medicaid after all.
Yep. Great. Karen?
Yeah, and this lifted up for me that there's a need to address some of the challenges experienced in these initial programs. And the top two in my mind of those challenges are one that none of them has really been able to address primary prevention or to do real social determinants work that isn't for folks who already have high health needs. And the other is that Connecticut really lacks an infrastructure for coordination between practices and among community-based supports. And that is something that a number of other states are pursuing, sometimes through methods we aren't interested in pursuing, like managed care contracts. But there are other opportunities, including in New York's 1115 waiver, for thinking about how to coordinate among practices and to coordinate among folks providing those health-related social needs services. And I think that's especially important because it's also just really hard to do meaningful accountability at the practice level. And if you have other means of coordination and accountability, there's a lot more opportunity. And I know that that's a big lift, but I think that without considering that, the potential for meaningful change is really limited. So I just wanted to raise those two things up.
Thank you. That's helpful. And Ellen, just on your comment, I hear you. I think it's really thoughtful. We want to be focusing on what our members needs, not on necessarily what CMS is doing. I do think it's important and we will plan to use a little bit of July to educate folks just on. It needs to be an intersection of what our members needs and what the feds will pay for. So we will use a little bit of July's time to bring everyone up to speed on the policy changes. Not saying that that's the right answer, but I do want to make sure everyone's on the kind of brought up to speed on the changes there. Angela.
Yes, good morning. just wanted to note on this committee's work on the slide, there's a reference in bullet 2 to referring members to providers who can help address these needs. Actually, I put in the chat, it assumes that availability and access to providers is a given, which it is not. Also, quote, providers might be primary care providers, but they might also be community-based organizations and others that can address some of the social and environmental needs. For instance, if a member has mold or lead, that's identified on a blood test that, you know, a child is exposed to lead. There are other providers like, for instance, Rebuilding Together Hartford, that might be able to come in and fix the lead and mold issue. Huge health impact could result, improves health, right? But that has nothing to do with an access to a physician, a PCP, after the fact. So how are you going to attribute and track all those environmental changes that might impact a patient's well-being that could, yes, be identified initially, but all the answers don't necessarily lie in primary care. And access to those primary care providers initially is, again, not a given.
Angela, it makes tons of sense. I'm tracking. Just a quick follow-up. As we think about our discussion in July and trying to make sure that we put together materials so that folks can have a good discussion, is there particular information that we can do to tee up the issue that you just raised?
I think an evaluation and a clear look at is twofold: the availability of providers in the various systems, whether it be FQHCs, hospital systems, private providers, what that looks like across the state, but particularly in those areas that have high rates of folks that are on Medicaid, would be critically important. And when you look at availability, availability to make an appointment as opposed to, walk-ins only, where you have to sit and wait all day.
That's helpful. And by the way, if you all hear me typing, I know I and the folks making the minutes are writing things down. And in the spirit of transparency, I'm asking this question. We may not be able to answer every ask that you have, but we want to make sure we're listening and hearing. And if we can't, at least for July, we'll be clear and at least explain why.
And the data on how many members are actually connected to PCPs, primary care providers. Like, there are folks that are walking around with Husky Medicaid cards in their pockets, and they do not have their own medical home. Yeah. That needs to be dealt with. We've had this conversation for years. It's been an initiative before. I don't know where we sit in terms of how are we doing. That would be good to know.
That's great. That makes total sense, Angela. And that I know we can bring forward. And I see David, thanks for that comment in the chat. Polly?
Yeah, thank you. Just and I think maybe it's where David was going is, this says, strategy for addressing. I don't know if you already have data from any of your member groups on what the prevalence of certain health-related social needs is. I know many of us have embarked on pretty extensive approaches to begin to collect this data. I think, fundamental to the health equity strategy is aligning and being able to collect and share some of these insights. But I don't know if you already feel like you have a base that could be informative, because I see housing and nutrition are called out. So like, why housing and nutrition under the 1115? What about other health-related social needs? The other thing I've been thinking about, through our internal conversations are things like health literacy and how to support members in health literacy, digital enablement, to support some of those access needs and taking advantage of, new ways to seek care. So just wondering how some of those strategies would fold into this, addressing health-related social needs that may be above and beyond kind of core food, housing, transportation, as well.
Makes sense. Mark?
Sorry, I have to get unmuted. So Ian, Brad, I would appreciate the opportunity in July to have two components to the conversation. One that focuses on downstream HRSN service coverage for sick people. And that's very much in line with what innumerable other states are doing today, Massachusetts, North Carolina, Oregon, and that sort of thing. And as you said, you've sort of queued up housing and food as food nutrition type solutions as important. I believe those important. It's ironic that we're inventing a fee-for-service system that is organized around care for sick people. So I would just note that that's a good way to grow capacity, and we need to grow capacity for community organizations to meet nutrition and housing needs for sick people. But I'd like to challenge really DSS to have a separate component to that meeting, which is about how to organize root cause upstream activities that are place-based and that would achieve or support both the primary prevention outcomes that Karen identified and that are the focus of preventive well visit counseling and primary care, and that would not be limited in their impacts to sick people, but they would certainly be important factors that affect healthcare outcomes. I know that no state is using federal Medicaid funds to support place-based activities that are not written into a treatment plan with a diagnosis. I believe that there are ways either through braided or blended funding, that is, if you think more flexibly about state funds that could be brought to bear, but also I believe that there's an opportunity to explore Medicaid-related financing strategies of the sort that Oregon and New York are pursuing with their waivers, but have not gotten approved, that are more about place-based cross-sector community action. So I recognize that that you could argue that that's not directly related to primary care capabilities, but it does directly affect the conditions that people live and work and that are necessary to achieve the goals of primary care. And I think if there were a discussion about an aligned strategy in some of these other areas, it might better enable us to focus on primary care as an element of, a multi-pronged approach.
Great. I hear you. Sense. Okay, I'm just going to move us along because I know we want to spend the bulk of the time responding to your ask for data and the poll that we sent out. Needless to say, if you have additional thoughts on this topic on how to make sure that a conversation in July is helpful, just shoot them over to me or to Brad. We're going to do our best to be responsive. We may not be able to respond to. We may not be able to satisfy all the data requests, but we'll definitely going to carefully consider them. Okay, Brad, do you want to take this one?
Yep. And so this is, as Guy already mentioned a little bit on this, a few things here just wanted to say is obviously being responsive to the timeline. So adjusting kind of the targeted launch date of a new primary care program to pushing this process out to January 2025 from July 2024. And so allowing for more discussions such as this and at the next meeting. And then as announced kind of, I think at the last meeting, we just wanted to say again, that PCMH Plus is being extended for calendar year 2024. And the other thing I wanted to flag here is on yellow box is that we think it really might be helpful for this group to get together for an in-person meeting. We understand some of the challenges with coordinating that, or at least trying to have most people in person and allowing for some hybrid nature. So we're going to be working to coordinate something later on, either late summer or early fall, so that we can spend some time sitting down together, discussing some of these topics, making sure that we can hear from you and to be giving us time and space to develop maybe hopefully some closer trusting relationships and get more input from your from your expertise and your perspective. So we'll be reaching out to help try to coordinate that, and we'll follow up with more details. And just to say, I think some of the things, just back to the prior conversation and some of the things that Mark and others are commenting on, is the conversation for this next meeting is meant to be broad and fairly expansive. And so I think the things that have been brought up as possible topic areas all are things that we're interested in providing space to explore and hear about, acknowledging some of these may be challenging for us to be directly responsive to for various reasons, but we obviously want to give space and opportunity to explore them and discuss them. Polly?
Thank you. First of all, I appreciate the adjustment in the timeline to give us the time. I love the idea of an in-person meeting. You know, one of the things I noted in this table is there's a lot of focus on the payment aspect of this. You know, it seems to be heavily weighted. You know, I just wonder whether we should spend more time upfront on some of the care delivery, quality, data sharing pieces that would set the foundation for a future discussion on then what does it look like to incentivize those things? Because I think there's a degree of let's get comfortable on what the work is and what the priorities are, and then how do we align the payment mechanisms to drive to that. I just don't know that in September we'll have gotten there from the work that we've done to date.
I'll just note this is, you know, kind of a tentative update we scheduled, so that's definitely something we can look at and think about. And I think part of this process is trying to be mindful that as we go along, we may need to make adjustments and move things around, and so just acknowledging that. So appreciate the perspective and commentary, Polly.
One super quick thing I'm going to say, if all goes well, I just a personal note, I'm going to be on parental leave for part of July and August. I really care a lot about this process. I'm going to either try to dial in or have Brad keep me up to date. Just flagging that if you don't see me on July and August, I'm not at the beach or whatever, just taking care of a new kid. So just wanted to say that.
Yeah, very important. Want to make sure Guy has space and time for that. Nichelle?
Just a quick question. As we're thinking about this, and you may have already shared this, but I'm not sure I heard it. I know we're at the close of the session. There's a lot of talk about the budget, and we're talking about redesigning this program, primary care program. Has the department thought about how much this might cost? And has that amount been thought about or included in this current budget? Does it have to go through the legislative process during the next session? How is that going to work? And will that impede or impair this current timeline?
Nichelle, let me take that one. It's a really good question. To answer, I think your second question, have we, and I'm playing it back and paraphrasing a tiny bit. So sorry if I didn't get it quite right, but your second question was roughly, have we reserved money in the current budget for this? And the answer is no, we have not. And part of the reason that we had an aggressive timeline before, which we've extended, responsive to your comments, was just thinking about how this work intersects with the budget process and stuff like that. So where does that leave us? I do anticipate that this effort will require funding. That will require executive branch support and legislative branch support. We do not have that today, in part because we don't have a proposal, in part because we want to coming to this with a very open mind. So I'm certainly aware of that timeline, and if in the fall it seems like we're circling, we're obviously not getting all the details worked out by the fall, especially with this new timeline. But if it seems like we're kind of circling and we have a little bit of specificity, I would be very supportive. I'm not speaking for Commissioner Barton Reeves, but I would, and I think she would be as well, in putting some sort of placeholder in the budget. But until we have a little bit more concrete idea on what we're doing, we can't kind of put placeholders for things that are sort of in the air. So that's how this timeline interacts with the budget process. And it's a really thoughtful question, and very much on my mind as well, as we have just a handful of days left in the session and no budget yet. So I appreciate it very much.
And I'll maybe just even that there's obviously a lot of other parallel processes that would need to occur depending on where we head, and even outside of budget, in terms of other processes, whether federal and state, et cetera. And so just acknowledging those are all things that we're going to have to figure out depending on where this process heads. Let's see, and thanks for those. Some of the comments, and I know, David, I don't know if you want to make any of those out loud. I saw some of them there. I think appreciate all the input on there. We'll definitely make note of them, but feel free if you'd like to share them out.
Sure. Just the most recent one that I commented on was, it struck me that we've been talking a lot about the investment to be made in whether it's the primary care practices or the primary care system or the system that supports primary care. But I think there's also that the state needs to recognize that there has to be an important investment in the infrastructure of the state to provide the data upon which or with which we'll be able to improve quality, share information with other sectors of health, not just healthcare, but sectors that have an influence on health, so we can coordinate care and address those health-related social needs that have an impact on health. So I do think that the state has to recognize that it's not only investment externally, but it's also an investment internally in state infrastructure to support this kind of system. If we don't have that, I think we won't be as successful as we could be.
Very much appreciate that comments, and thank you. Just given time, I want to make sure we have some time to talk about some of the curated slides that our Faulkner team has put together and helped pull together last year. And so go to the next slide. That just to note that just very brief reminder, we spent time last year going through these different assessments, these three components. You've seen the slide before, and this is some of the information that's been pulled together. I'm going to pass it over to Olivia to kind of go through that, and we appreciate the input that you all have in terms of what you'd be interested in talking about today. Key, did you want to add anything else?
Yeah, the only other thing I'm going to add, there was a lot of information here, right? And when we were meeting, we were struggling. We want this to be a discussion. We want to be responsive to what, in part because you all asked for this data and information. So I just want to call out part of the reason that we sent the material far in advance. We asked the poll to kind of direct us a little bit, was to help us try to curate. We're not going to be able to cover everything in our time. I am happy, I think Brad is, our Faulkner partners as well, to if there are certain topics that need a little bit more attention with a subset, we're happy to do that. And Ellen, this isn't the only bite at the apple, but we did want to be responsive right away to what we heard in the last meeting. So just wanted to ask for your grace that we're not going to cover everything. We're not going to try to, and I think we're going to try to use it a little bit more on, hey, here's what we're seeing in the data and discussion, rather than trying to cover barraging you with information. So that's just the context I wanted to give there.
Thanks, Guy. I'll pick up from there and say, exactly in line with what Guy just said. There's a lot of information in the document that you all received after the last meeting. And so what our attempt with the pre-meeting poll was, and thank you for those of you that were able to respond to that, we did score the results, and we used those to sort of rank order the topic areas in the document. from most interest amongst committee members to least interest, in the hopes that we would at least be able to organize today's conversation such that we're, spending the most time on the topics that you all want to spend time on. That said, I will try to leave 10 to 15 minutes at the end for those of you who may have questions or comments about, topics that are at the bottom of the list. So we make sure we do try to give voice to those as well. So not to say we'll only be talking about topics at the top of the list, but we'll try to use this at least as our preliminary organizational frame for today's discussion. And then I would, reiterate, you all have this compendium in your hands, please look at it, go through it, and know that we are happy to, answer questions that you may have. This is not the only opportunity. It's not the only bite at the apple. So if there are things you want to talk further about or pieces that you'd like to have, please feel free to raise those things, in today's discussion or in follow-up. As we go through this, let me throw out 2 framing questions for you all to think about. And again, we're going to try not to barrage you with information, but to have you help us navigate what we look at and discuss together today. The 2 things it would be helpful if you all could think about as we're going through this are, 1, if there are items in the compendium that you want to review in more detail. Again, recognizing there's a lot of information and we're happy to skip around to different pieces of the document. In fact, that's I think what we're going to need to do. And actually with that, I'm going to apologize for making the slides a little bit more difficult to see, but so that we don't have to flip through all of the slides as we try to move around here, I am going to just move us into a different view so we can navigate the appendix a little more readily. The second thing I want to throw out to you all as a framing question to think about as we go through this is, what other data or information would you like to see? So we know from the pre-meeting poll that there were some, specific data requests already that we got within that we are going to, we've started basically a running list. I will say, just for awareness of the things that are already on that, we have service utilization by population, we have pediatric cost, quality, and outcomes data. We have access for different geographical areas in the state, and we have prevalence of chronic conditions. We'd like to, keep that list going. I know we've already heard some other requests at the top of the meeting, so feel free to add on to that as we go, and we can take that whole list back, to figure out what data we have available to fulfill those requests. So with that, let me go ahead and move us forward and say we'll start with access and participation as the highest interest topic. I want to ground us just quickly using some of the key findings around access and participation in what is contained in this section, just so we have our heads around what's in this component. So from an overall perspective, we're looking at things like multi-state benchmarking of primary care access and preventative care measures. So looking at how the Connecticut Medicaid program compares to other states in terms of access and in terms of access measures. We're looking at network adequacy. So for PCPs and pediatricians, and then from a program specific perspective, we're looking at provider participation in the PCMH and PCMH Plus programs in terms of both the number and kind of practices or providers participating in those programs. And then from an equity perspective, looking at things like the distribution of attributed members by different provider settings and race and ethnicity, as well as looking at measure performance on measures in access and prevention and screening domains by race ethnicity. So there is a number of different places we could go in terms of the data that we have within the compendium around access and participation. I'm going to flash this up and say, again, network adequacy, so access to PCPs and pediatricians, multi-state benchmarking around measures like adults lacking a personal doctor, state population in designated primary care health professional shortage areas. We have Medicaid CHIP scorecard performance data, again, around access and preventative care. We have some health equities data around prevention and screening and access and availability, primary care spending across states, provider participation in the PCMH and PCMH Plus programs, as well as member attribution by race ethnicity. So let me turn it to you all and say, are there particular items in this section that you would like to review in more detail at this point? Or is there other data or information related to this topic that you don't see or haven't seen in your review of the document, don't see listed on this page that you'd like to raise as important context? Mark.
So I carefully looked through all the data that you have here and also data that was presented in December by CHN Connecticut on number of individuals impaneled. And I know that only 60% of Medicaid adults are impaneled today or were in December, and 80% of pediatric children, which makes a lot of sense. And I'm trying to understand sort of what to make of that. And I also hear, and there's so much data, we can't go through it all today, right? And really have everybody understand it. So one of the things that would be interesting for me, just one person, is what are the insights you have in terms of that question of primary care capacity and access? What are the takeaways? Because it would look to me that we have better than average performance nationally, but I hear a lot. I don't know whether some of my colleagues want to speak to that, but I hear a lot and heard in the opening discussion that primary care access is a problem, that people can't get a provider when they need it or get back to a provider when they need it.
Mark, I will take us back and just say at the sort of highest level, because I agree our challenge today is really that we won't be able to go through all of it. And I hear your requests for sort of, well, what does it all say? And I would say, as that you're right in interpreting this, at least as we have, that from a sort of multi-state perspective, Connecticut does perform, relatively well on measures of access and preventive care. So for that, we can look at things like the Medicaid CHIP scorecard measures. And I think, there is a challenge in squaring sometimes the way things are measured versus what we hear, right? I think what we've heard in this meeting and, what we've heard in the focus groups and in other contexts around access, which is to say, you'll see here, it says there are no major gaps in CMAP member PCP access, as measured, which is to say, we might debate whether the measures are adequately or meaningfully, measuring that sort of experience that a person might have in trying to access care. So what that bullet refers to, right, is the fact that, nearly 100%, I think, 100% of adult Husky Health members do have access to an open panel PCP within a defined geographic distance. That said, I think, we certainly hear in the context of, again, this meeting and others that, that doesn't necessarily describe the lived experience of someone, seeking care and struggling to find access to that care. So, I want to both hold up that feedback that we hear and also, acknowledge that from the, the perspective of the data that we have, we have not seen the data, at least from a sort of network adequacy and geomapping perspective, does not suggest that there are major gaps in member access to PCPs with open panels.
Maybe just one quick question for you all, either in this session or offline. This is also a question we have teed up, and I am going to tee up again for our member advisory group, which is a group of paid members that we ask for advice. But I'd love either now or offline, your sense, especially Angela, that you brought up access now several times, on what are the gaps that you're seeing that may, as Olivia's saying, may not be measured in the data that we're having, because that may point to the problem that you're hearing from our members. That would be really valuable. And Mark, I just wanted to touch on something as well that you mentioned briefly, as did several folks, I think, including Angela earlier, about unattributed members. And I do think that's a really important topic that we can figure out when to do on the schedule a deep dive on that. But I would love to get this team's thinking about how we help match members who may need primary care, who aren't accessing it for one reason or another, to primary care doctors who are going to be good for them. I just want to call it. I do think that's an important topic that we can put on the agenda at some point.
Hey, James, I think you're next with the hand up.
Jim, I think you're up.
Thanks. So this gets a little bit to the question of you that it's around, experience, and I haven't looked at it recently, but if we look at our ED utilization, Medicaid is a much disproportionately user of ED. And I know, without needing to do a whole lot of data, but just call and try and get a PCP appointment, that we've got huge problems with PCP access. So this is where getting the insights and really digging into it, it becomes really important, because you can provide the data, but to say there may not be any gaps to the potential access, but are patients seeing PCPs? Because if we're driving this all to saying we need to make sure they're not just have access to it, but they're actually accessing and impaneled, it becomes a critical data point for us to see if we need to address. And then looking at, okay, for those that are actually impaneled and seeing PCPs, and I'm just speaking about ourselves, with those that are not, is there a huge disparity there, and does that need to be addressed? That's the kind of insights that we sort of need, because I think before we get to, and this was mentioned earlier, is that before we figure out what we need to flow incentives to, we got to, again, really take the insights from all the data that you have and bring that forward to say, what's the immediate problem that we want to incentivize to solve? And if it's, we just need to get these people impaneled into a PCP, that's going to open up a whole series of things that we need to address, and in of itself is going to be a major lift. And that's the kind of where I'm stuck. I'm not you can provide me a lot of data, and you did, but I'm not a data analytic guy. I'm really looking for the insights you have. And it worries me a little bit that the first billet on this, it really doesn't fit with my experience with what I think is going on. And I think that this population has real challenges seeing a primary care, and even more challenges seeing specialist care. And I just think we need to acknowledge that and say that's a problem that we need to kind of dig into a little bit more to figure out, because we can take better care of the people that are seeing our primary care, but boy, that's probably not going to be satisfactory for what we're trying to do.
Thanks, Jim. And I think back to what Olivia says, like, what are we measuring? Are the measures capturing everything? Access may mean someone's open for impanelment, doesn't mean the right provider at the right time. Do providers have the incentives to be able to see individuals and be flexible and actually meet their needs as well? And so I think, there are some insights, and some of this is going to be prioritization of what we think is achievable through this process and what's realistic, but appreciate it.
And I think, Brad, I really appreciate that. It's the data literacy part, is that you have the data, and what we need to do is, what is the data telling us and what can it tell us? It's as much to don't draw conclusions. You can't draw the conclusion that everybody's got access to a primary care, I don't think, from the data. That'd be my guess. But we should call that out. With the limited data we have, this is what we see. But it does not suggest that we don't have a primary care access problem. And yet this would give you an inclination that it isn't a problem, but I suspect it probably is.
Appreciate that. The other thing I'll just hold up is that I think there is, just in terms of what we do have within here, the sort of quantitative component and the qualitative component, which is to say, to the point of, we have the measures that we have. But I think, in looking at the qualitative, we do hear more of that and do capture. So I'll just acknowledge, and agree that there is a disconnect, right, between some of the data that we have in terms of how things are measured, and then some of what we hear, both what we heard from members and providers in that qualitative data collection and what we're hearing now. So appreciate you raising that. Ellen, I believe you're next.
Yeah, this is really good. I love this stuff. Thank you. I was very happy to see that we have great access. I guess I also have come to understand that isn't everybody's experience. And I've spent a lot of time lately delving into the world of people with disabilities, particularly developmental disabilities. And just because there's an open appointment they're taking appointments does not mean you can get in. There are a large number these are national surveys, but disturbing numbers who are not welcoming people with disabilities because they take more time, and I mean, it's understandable. So I think we need to look at the subpopulations. There may be some where you find it much, much higher. For instance, if you look at the number of uninsured in Connecticut, it's really low. But if you look at non-citizens, it's really high. So we have some, we need to look underneath the data, the populations. I think ED visits are really important to look at, but I don't know that we should assume that because ED visits are high, there are plenty of people who come into the emergency room who have a primary care provider. There's evidence around this, who are seeing that primary care provider, but they're still coming into the emergency room often. There may be other problems going on, and maybe there are things we need to work on with primary care. If it is something, those ED visits are things that would have been, if they were avoidable, based, because with good primary care. So I think we need some more evidence under that. I remember when Massachusetts passed their reforms, their chapter, whatever the number is, and people got health care, the number of primary care visits went up, but so did ED visits. As people get more involved in their health, they'll start accessing more care. And some of that's going to be in the ED, and we have to figure out a way to address that. But it's not just to see high numbers of ED does not mean a failure of access to PCPs.
Thanks, Ellen. Robin, I believe you're next.
Yes, thank you. As I was listening to the conversations also, and even as a pastor, and also, and also a faith-based community organization, I think that, some of the things that were said, the number of visits, especially that I've seen and heard persons going to the emergency room that were not necessarily emergency visits, needed to be emergency visits, is around the lack of having a primary care doctor. So I'm not sure what data that is, but I'm just, really speaking about, and many other faith or leaders would also say the same thing. And some of it is also in not having access to a primary care doctor or to their primary care doctor, or have not developed a relationship or the confidence that the primary care doctor is paying attention to what their needs are and the emergency that they feel that they have, or their healthcare needs. Also, and usually it's the last, kind of the last result that they go to the hospital, but it really is because they don't have a primary care doctor, or they feel that whoever they're seeing is not really attentive to their needs. And so I do think that those are some of the things that we have to really think about. And also, not only that, but also there's many people that are still not, that are uninsured, also. And so that's another, thing of not having a primary care doctor and really, getting to the place in which it is an extreme emergency to actually get to to go to the emergency for those visits. I do think that it's great to have data, but I do think you have to really also, get stories, also, and hear from the people in terms of them telling you why and why it is difficult for them to have why it is difficult for them not to have access to their primary care doctor when they do feel that something is an emergency or important, or they don't have a primary care doctor because also the medical field has not always been so kind to them.
Thanks, Robin. Appreciate that. And yeah, just we'll agree again and not spend too much time going through this, but do want to acknowledge that this is, consistent with what we heard in a lot of the focus groups in terms of availability and access to care and the importance of that to members and some of the real difficulties that members experience with that. So I do want to acknowledge that, that is it's a very important point, and that there is, some additional information from the qualitative perspective. I think certainly we need to both look at what the data says and also listen to the stories and the people. And so appreciate again you raising that. I think, Mark, you're next.
Yeah, great. Just to build on and be supportive of the comments James, Ellen, and Robin have made, sort of 3 points. One, I think a few years ago, and Nichelle might remember this, DSS gave us list of unattributed. I think our organization got 100,000 names, or a very large number, and the other FQHCs in the state also received them. So we know there's a large number of currently enrolled Medicaid patients that aren't attributed to a primary care provider. Doesn't mean they're not getting care somewhere, but using the methodology the state does for what an unattributed member is. And then on the issue of access, patients may have a provider, but not at the time they need them. And I'll give you an example. On Monday, average, we get 4,000 to 4,300 calls a day. Yesterday, this week, because the holiday, was over 5,000. This is sort of the practical reality. And I think, I don't know if James would agree with this, but, utilization high on Monday, drops as you go throughout the week. Just the technical ability to answer every call in a timely manner is a real practical problem, right? Because if I don't get it, I think I have a problem, I might end up at the emergency room because my primary care provider on that day, Monday, is a very, very difficult day to sort of execute on. The other thing is, we've got a lot of people who are in the queue on specialty care and don't have access to the specialist because there's a long line. And if you've been referred by your PCP for a cardiologist and somehow you're not feeling well and that phone isn't being answered, you're down at the ED. So I think we have just some, the execution on the theory of delivery is a complicated one. And it, requires all sorts of detailed analysis of between the lip and the cup. What does it mean that thematically that there's access when on the practical matter of trying to execute it, it's a complicated task for which for those of you who know, obviously we have our Weitzman Institute and others, but we should be thinking internally about building capacity for providers about the management, the organization and management of their practices, right? To the extent that we can help out that delivery system, not only theoretically, but on the practical basis. Thanks.
Yeah, and one quick, thanks for that, Mark. I want to acknowledge and lift up, I think Robin, Ellen, and you have all, and others have brought up the important topic of unattributed members. Who are they? What are we doing? What are some of the barriers? I just want to say explicitly, hear you. And Brad and I will figure out I do think that's an important topic in of itself, and I think we could start with the data, paint that statistical portrait of who those members are, share the qualitative feedback, and then we'd love to brainstorm kind of what we do about that. So I just want to say I hear you, and we'll figure out how to weave that into the schedule, because I think that's a really important part of this picture.
Are you at the church?
Yes, I'm at the church. Are you still meeting?
Yeah, I'm on my way.
Okay, thank you.
Yeah,
All right.
And I just wanted to acknowledge there are a lot of really thoughtful comments in the chat. I don't think we'll necessarily respond to every single one of them, but I'm reading them. Just sometimes if there are parallel conversations going, it can get tricky. But I just want to say I'm reading them and thinking about them, and they're really helpful. So keep them coming.
Great. With that, and seeing no other hands raised, and just in recognition of time, I'm going to go ahead and move us to the sort of second topic here, which was around the evidence-based. So just to orient folks to what we have, again, we won't, review this in detail, which is to say I won't read everything, on this slide, but in terms of results to date, from an evidence-based perspective, we looked at a range of studies, and the sort of key finding here is, and you'll see the findings sort of segmented by payment model type below, as well as some findings specific to equity, just to disparities in care and reductions in disparities. We see from the sort of overall perspective is mixed evidence, but little evidence of negative impacts on quality or outcomes, and from an equity perspective, from the disparities reduction perspective, an acknowledgement that most VBP models have not historically directly incorporated disparities reduction into the incentive structure, and programs that have been designed for general populations, have not consistently reduced disparities. CMMI has taken a pretty close look at this around the Medicare ACO programs, and so there are a lot of interesting findings there in terms of disparities reduction and where programs for more general populations, what kinds of results they have had. So, Ellen, I know you have already said that you will have comments on this section, so appreciate that and certainly welcome them. I want folks to know this is a sort of significant piece of what is contained in the compendium. There's detail around each of the sources. There is also, and I will just, while we're on the topic, flag, given that it was our sort of third priority topic, some information around lessons learned. So in addition to results to date in terms of outcomes, some sort of recommendations for both payment model design and program implementation. A lot of these come out of the work that CMMI has done in evaluating, the past 10 years of federal value-based payment initiatives, as well as state Medicaid programs, et cetera. I think a big question here that's already been raised, so let me just acknowledge it by flipping to the details here just quickly, or what sources are contained in this review. I would point you here just in terms of a sort of quick overview of the kinds of things we looked for. So we looked at systematic reviews, these being typically studies that look at, a broad range of studies of various VBP models. We looked at base payment assessments as a sort of distinct category. We looked at the CMS Innovation Center models, again, that being probably the most sort of robust evidence base that we have. We looked at state Medicaid program models, which is a little bit more piecemeal, right, in terms of the kind of evaluation that's available, and in terms of the level of adoption of value-based payment, within Medicaid programs. And then the bottom two primary care startup models, which there's very limited evidence on, and which we would, I think, classify largely as less reliable than the other evidence categories. And then driving equity through payment. So some of those more detailed looks at disparities in care. Ellen, I see your hand raised.
Yeah, I guess, I said I needed more time, and I do, but I am struck by that a lot of the sources relate to the things that are medium high reliability are not Medicaid based. And I say this over and over and over again, that Medicaid is different. It just is in many, many ways. It's a different population with different resources, different benefit package. We don't have copays to drive people, steer people in certain ways. We also, it's a very high cost, high need, not high cost, patient, but we pay providers much less than in others. It's a little like, this isn't apples and oranges, it's apples and Chevys. So some of those, have, I think, you really shouldn't even look at them, to some of them, frankly, because they have resources and they have patients who can more easily, you can connect them with certain things and they will, get what they need. And that's not always true with people in Medicaid. So I would really spend a lot more time on the state Medicaid program models and how those worked in other states and didn't, as opposed to something that worked in a state employee population or commercial, very rich, or even a bare bones, something like a bronze plan that's not that has very little overlap, frankly, with Medicaid. So I think we have to be careful about making assumptions and drawing conclusions from something that's high reliability for a completely different population.
Yeah, I mean, I think, Ellen, I understood. Yeah, this is always a challenge, is like, not just in this area, but even in the practice of medicine, where we often are extrapolating information from data that's similar, but not exactly the same population. I would argue it still is important to look, because it's still, there's still people, obviously the population is different. And sometimes there are some different incentive structures, like you said, with co-payments or deductibles and other things, but it's still hard to say, ignoring it, given the limited data in this space. And I think the importance of at least looking at it and saying, hey, could we learn something from this? But I hear some of your concerns for sure.
Mark.
Just a quick comment on, I guess I'd like to test my assumptions, the insights that I gleaned against, say, Brad, Olivia, and Tiffany, what you gleaned. It seemed to me, sort of big picture, on the whole, the models are mixed in terms of their outcomes. And there's a fair bit of evidence showing some cost savings, and some is around avoidable hospital use, ED or otherwise. And some, I noticed there were some studies that we reduced unnecessary specialty visits and procedures or low value care. So one of the questions, of course, when we talk about goals is that a problem we have in Medicaid? If it's not, that, if it is, that has a different set of requirements from a capabilities perspective of focus and that sort of thing. So is it really about avoidable hospital use, or is it about these other things? So I was really struck by the lukewarm, we didn't make quality worse, and maybe it was a little bit better, and the kinds of things they were measuring weren't very inspired. So correct me if I'm wrong, but I didn't see any marked impacts on the conditions that most dramatically impact life expectancy and quality of life as one ages: hypertension and cardiovascular risk and diabetes. And I may be missing it, but I think I was really struck by the fact that it's a substantial impact on the conditions that arguably predominate in the Medicaid population just wasn't there.
I will venture a quick response and say, Mark, I think you're reading the high level findings, appropriately, which is to say that the evidence is broadly mixed. and that there is a lot of focus on, I would say, small improvements in quality and outcomes, and findings that, there have not been detrimental impacts to quality or outcomes, associated with the cost savings incentives that are associated with most of the models. Part of what's difficult here, I will say, right, is that in trying to be broad-based, and we've included, in this pretty broad-based review, a number of studies that are broad-based themselves, right, that are systematic reviews of, say, 60 programs, is that, we do have a sort of flattening effect in terms of the, successes and failures on either side. So I think it's absolutely right to say that from a sort of summary overview, it's hard to say much besides that the outcomes have been quite mixed, that there have not been detrimental impacts to quality or outcomes, but that there have also not been consistently positive effects on quality or outcomes or on chronic conditions management. I'm aware that we have only a few minutes left. And so I do want to just sort of open it up to say, without being topic specific, if there are, other questions that are burning on your mind that, we can address at this point, happy to do so. But I will also reiterate, given the limited time left, that this is not by any means the only bite at the apple. I think we have a pretty, a pretty good list of various requests. So certainly we'll take that back and take a closer look at what else we can provide around that. Ellen, go ahead.
I guess, we're starting again with value-based payment and looking at the models and how did they do. I would love to know if we could look at what the ones that succeeded actually did, and then find out how to get to that instead of starting with value-based payment and assuming, because how you pay providers is not direct healthcare. It's, it changes incentives that we hope in a certain way gets us to something good. Can we find out what the good thing is and then figure out how to pay for it, or at least have some data around what are these innovations that, made a difference? And, you're right that overall things are kind of, the juice just really isn't worth the squeeze. But there's a lot of variation in there. And this is one time where I'd love to know. I don't usually want to know from case studies because that starts you out with, this great optimism and first adopters bias and all that. But if we could look at some of the innovations that in primary care that have made a big difference for people in Medicaid, not lowering low value care when providers are already underpaid, things that really work. And then we could move back eventually to figure out how to fund that. That would be helpful.
Thanks, Ellen. I hear that.
Great, Olivia. I know we're at time. I just want to say thank you. Really appreciate the engagement. Hopefully this new format works for you all. We're trying to really carefully listen and play back to what we're hearing. Put on your thinking cap for July for the health-related social needs discussion. If there are other things that you think would be helpful in advance of that, let us know. Thank you. Yeah, happy almost summer. Just for those of you who are more connected to the legislative session, only a handful of days left. So we'll all have fewer bags under our eyes coming Thursday, or the first day after the end of session. Thank you so much. And looking forward to seeing you all in person. We'll figure out the logistics of that, but I think it would be great, schedules permitting, to have at least one session where we're together in the same room. So thanks again. Take care.
Thanks, everybody.
Bye.
Thank you.